Dr. Bhaskar Kudatini, are you here? Dr. Bhaskar Kudatini is going to talk about interplay between primary chronic dacryocystitis and meibomian gland health.
Good morning, everyone. Today my name is Dr. Bhaskar from Mysore Medical College. Today I am going to present interplay between primary chronic dacryocystitis and meibomian gland health. Ethical clearance was obtained from the Ethical Clearance Committee and financial disclosure is nil. The primary chronic dacryocystitis is defined as inflammation of the lacrimal sac, typically caused by the obstruction of the nasolacrimal duct, and meibomian gland dysfunction is a common comorbidity of the primary chronic dacryocystitis. This is how the meibomian gland dysfunction is occurring in PCD is mucopurulent discharge is causing chronic inflammation and bacterial colonization that is leading to altered tear film composition and meibomian gland dysfunction. These are some photographs showing chronic dacryocystitis. Need for the study is understanding the relationship between the primary chronic dacryocystitis and the meibomian gland dysfunction and the impact of the DCR on DCR. The aim is to evaluate association between MGD and PCD and effect of DCR on tear film stability and MGD. Materials and method, it is a prospective interval study done for the period of 1 year. We have included adult patients diagnosed with unilateral acquired PCD. We have taken 50 cases and 50 controls. Controls are other normal eyes of the same patient. PCD was diagnosed based on the epiphora, mucoid and mucopurulent discharge with the nasolacrimal duct obstruction confirmed on syringing. We have taken detailed history and comprehensive examination done. We have assessed based on 12-item ocular surface disease index questionnaire, MG expressibility, T-BUT, tear meniscus height, Schirmer's test, and we have done DCR and followed up for 8 weeks. Results, we have taken almost 74% of the female patients were included in our study and 50 cases and 50 controls. Age range between 21 to 75 years. MG result, MG expressibility, initially it was high, post-operatively it is decreased almost grade 2, more than or equal to grade 2 was found in more than 90% of the patients. Schirmer's and tear meniscus height initially high, it is decreased to almost near normal. The preoperative high values may be because of lipid deficiency and decreased drainage and reflex secretion. T-BUT is high initially, maybe because of gland destruction. It is post-operatively increased. OSDA score is also decreased post-operatively, but it does not come to normal, maybe because of permanent meibomian gland destructions. This is the photograph showing pre-operative and post-operative tear meniscus height, significantly reduced TMH post-operatively. Discussion, MGD is a vicious cycle in PCD. Chronic inflammation is causing meibum stagnation and hyperkeratinization, and melting point of the meibum is increased. It is leading to gland obstruction and atrophy, leading to MG damage and MGD. As I mentioned, MGD prevalence is increases with age. 72% in those aged more than 60 years. In our study, 7 out of 50 subjects aged more than or equal to 60 years. MGD is more common in men, but the study had more females due to PCD being more common in females. R. Goyal et al. Concluded the strong association between PCD and MGD. J. Hong et al. Demonstrated significant changes in meibomian glands in patients with unilateral PCD. As I mentioned earlier, Schirmer's and TMH may increase compensation for lipid deficiency in early MGD status. Post-operatively, tear secretion is decreased as the tear outflow was restored. T-BUT reduction in PCD is likely due to goblet cell destruction from chronic inflammation. Post-DCR, T-BUT increased to the level with controls. OSTA score improved after surgery, indicating symptoms relief, but remained higher than the controls. Limitation of this study is we don't have meibography in our institute. We did not do this. and lack of TR inflammatory cytokines, pre-existing MGD before PCD is not ruled out, short follow-up period. Conclusion, PCD can cause significant functional and morphological disturbance in meibomian glands leading to MGD. Strong association between PCD and MGD likely due to chronic inflammation induced gland obstruction. DCR surgery can restore functional meibomian gland changes and TR film stability, but does not reverse the structural meibomian gland loss. Thank you.
How do your findings correlate with existing literature on the same kind of study?
It's almost near normal, ma'am, with reference articles.
Most of them?
Most of them.
Any major study which you know?
Or at Goel, or Goel et al.
You mentioned it?
Yes, ma'am, I mentioned.
Okay, okay. All right, thank you.
So in a patient of PCD, regarding the PCD patient will come to you many a times with just complaints of watering. What would you counsel the patient?
Discharge, ma'am.
The patient comes to you with watering complaints. What would you counsel the patient regarding, in reference to your study?
Mucopurulent discharge, ma'am.
It's okay. Good presentation.